Usually when people picture surgery, they envision this perfectly sterile, brightly lit environment, right? Where everything is just rigidly controlled.
Oh, absolutely. The surgeon asks for a scalpel, makes a precise incision, and simply fixes the anatomical problem.
Yeah, it's perceived much like a master mechanic replacing a broken alternator in a high-end sports car.
We really do find comfort in that visibility. The prevailing public perception is just highly mechanical and, well, binary. The tissue is torn, so you sew it. The organ is necrotic, so you remove it.
But the reality that you face when you step into the operating room, or worse, the trauma bay, is that the sports car is actually on fire.
Yeah, that's a good way to put it.
And the mechanic has to figure out how to put out the flames while the engine is still, redlining. We're looking at a physiological environment that is incredibly volatile.
Exactly. And mastering that systemic chaos rather than just mastering the physical act of cutting is really the true mark of surgical mastery.
Which brings us to our mission for today. We are taking a deep dive into the core clinical wisdom of Schwartz's Manual of Surgery, 8th edition.
A true foundational text.
It really is. So for everyone listening, whether you are a medical student prepping for boards, a resident, or just someone deeply curious about medical science, we are skipping the superficial stuff today. We are going straight into a strategic review of surgical pathology, patient management, and operative technique.
And what becomes immediately clear when you study this text is that modern surgery requires an obsessive understanding of the systemic response to injury.
Right.
It demands knowing the deep physiological why behind every single technique. Because before a scalpel ever touches the patient's skin, the systemic response to the environment of care is, well, it's already dictating the outcome.
And a massive part of that environment involves the potential for systemic error. The text cites an Institute of Medicine report stating that between 45,000 to 98,000 medical error-related deaths occur annually.
Which is just a staggering number.
Oh, it is. And when you look closely at those numbers, it is rarely like a slip of the scalpel that kills the patient. It's the breakdown of the system surrounding them.
The processes of care are usually the culprits. What's fascinating here is that the manual explicitly highlights communication failure as the single most frequent cause of errors and complications.
It was poor communication.
Yeah. You often have brilliant, highly skilled surgical and anesthesia teams working on the exact same patient, but they operate on radically different patterns of care continuity and on-call availability.
So things fall through the cracks.
Right. If they aren't mutually and concurrently aware of the patient's minute-to-minute physiologic status, say, from the preoperative holding area right through the postoperative recovery phase, vital data drops.
Okay, let's unpack this using an analogy. I think about commercial aviation protocols here.
Oh, that's a classic comparison.
Okay. Because if pilots and air traffic controllers relied on highly individualized, non-standardized communication styles, planes would be falling out of the sky daily.
They absolutely would.
They use strict readback protocols. Yet, traditionally, surgical culture has prided itself on this sort of captain-of-the-ship individual preference, right? Where surgeons just do whatever works best in their own hands.
Which is a very old-school mentality.
So why do surgeons still cling to highly individualized techniques if it causes system failures? Why is standardizing care plans so critical for the whole team?
Well, standardizing care plans isn't about stifling surgical artistry. It is about creating predictable redundancy. When the entire team knows the clinical pathway, you eliminate the cognitive load of guessing the next step.
That makes a lot of sense.
And that standardization is incredibly crucial for post-operative physiological management, particularly with fluid balance.
Because the body is freaking out after surgery.
Exactly. A patient comes out of a major abdominal case, and the surgical stress response has triggered massive surges of antidiuretic hormone and aldosterone.
So their kidneys are basically hoarding sodium and water.
Yes. The risk of iatrogenic volume overload is immense.
And catching that volume excess early is where standardized metrics really shine. Because you can't just look for peripheral edema, right?
No, you really can't.
A patient can have a massively overexpanded extracellular fluid compartment while their actual circulating intravascular plasma volume is depleted.
Right, the fluid is all in the wrong spaces.
So the benchmark rule from the text is remarkably simple. An average postoperative patient who is not receiving nutritional support should lose approximately 1/4 to 1/2 pound a day.
That's the golden rule. Weight gain is the absolute earliest sign of volume overload.
Wow, just watching this scale.
It's that simple. And to manage this, the manual advises that initial resuscitative fluids should be isotonic to restore that circulating volume.
Like normal saline.
Exactly. However, After the first 24 to 48 hours, you have to transition to 0.45% saline with added dextrose.
Half normal saline. I want to break down the mechanism behind that transition because it's so important. Pumping a patient full of 0.9% normal saline continuously, that's a recipe for hyperchloremic metabolic acidosis.
Because of the massive chloride load.
Exactly. So by switching to 0.45%, you are providing free water, which the kidneys desperately need, to excrete the daily osmotic solute load without forcing them to process excess sodium and chloride.
The physiology dictates the intervention. You only add potassium to that maintenance fluid once you have confirmed normal renal function and adequate urine output.
To avoid fatal hyperkalemia, right?
Yes. And we see the same principle of letting the physiology dictate the intervention in metabolic support too, specifically regarding corticosteroids.
Oh, this is a dogma that is actively shifting.
It really is.
The traditional teaching was always to blast patients with stress-dose steroids around the time of surgery to prevent an adrenal crisis if they had, any history of steroid use.
Right, the old safety net.
But the manual strongly pushes back on giving superphysiologic doses to patients who are only on low-maintenance doses, like, say, 5 to 15 milligrams of prednisone daily.
And the mechanism of the hypothalamic pituitary adrenal axis explains why.
The HPA axis.
Exactly. A dose of 5 to 15 milligrams of prednisone just does not cause profound suppression of the HPA axis. Therefore, parenteral treatment for these patients only needs to replicate their daily physiologic replacement.
So no massive stress doses.
Right. You only consider additional stress doses if they're on 20 milligrams or more of prednisone a day, and even then, you taper it off within 2 perioperative days.
Because giving massive stress doses unnecessarily just invites wound breakdown, hyperglycemia, and immunosuppression.
This is more harm than good.
Okay, so if fluid and metabolic management require that level of systemic precision, massive hemorrhage requires knowing when to abandon precision entirely.
That's a great pivot.
Transitioning from elective safety to emerging chaos, let's step into the trauma day. We are dealing with shock. And as any medical professional listening knows, defining shock merely as low blood pressure is a dangerous oversimplification.
It's way more fundamental than that. Shock is a cellular disease.
Right.
It is the inadequate delivery of oxygen and nutrients to maintain normal aerobic metabolism that forces cells into anaerobic glycolysis, lactic acid production, and eventual cell death.
The low blood pressure is just a late-stage macro symptom of that microvascular failure.
Exactly. Because the initial cellular injury is reversible, management has to be heavily empiric. You are restoring vascular volume and oxygen carrying capacity before you even have the luxury of a definitive diagnosis.
And in cases of severe penetrating abdominal trauma where the patient is just massively bleeding out, we utilize damage control surgery.
This is a crucial concept.
The best way I can visualize this is dealing with a flooded house. If you walk into your home and the main plumbing line is burst, you do not start meticulously hanging new drywall and painting the trim.
No, you definitely do not.
You find the main water valve, you turn it off, and you get out to let the house dry. In damage control, the goal isn't to meticulously suture every liver laceration.
Right. The sole priority shifts from definitive anatomical repair to physiological survival. You physically pack the hepatic or splenic lacerations with laparotomy sponges to provide tamponade.
Just pack it and go.
Pack it, temporarily close the abdomen, and rush the patient to the intensive care unit.
So what does this all mean for the surgeon's ego? I mean, stepping away from the operating table without actually fixing the anatomy goes against the entire psychological ethos of being a surgeon. You are trained to complete the repair.
Oh, leaving the job half done requires immense discipline. But you really have no choice once the patient enters the deadly triad.
Coagulopathy, acidosis, and hypothermia.
Yes. You cannot fix anatomy when the physiology is actively dying.
It's a vicious cycle.
It is. Hypothermia inhibits the temperature-dependent enzymatic reactions of the coagulation cascade, so the patient literally cannot form a clot.
Which means they keep bleeding.
Right. That ongoing bleeding worsens hypoperfusion, which accelerates the lactic acidosis, and that acidosis depresses myocardial contractility, dropping cardiac output and further worsening the hypothermia.
It is a literal lethal feedback loop.
A death spiral.
So in the ICU, the team aggressively corrects the acid-base balance, administers massive transfusion protocols with fresh frozen plasma and platelets, and forcefully warms the patient.
And the manual sets a hard physiological floor here.
Okay, what is it?
You must reach a core temperature of at least 36 degrees Celsius or 96.8 degrees Fahrenheit before you even consider returning to the OR for the definitive repair.
36 degrees Celsius, that's the magic number.
Yeah.
And once you are back in the OR, finding the source of the bleeding often requires aggressive anatomical maneuvers.
Definitely. If a patient has a massive venous hemorrhage from the retrohepatic vena cava, you must immediately perform a right medial visceral rotation.
Mobilizing the right colon and duodenum to expose those great vessels.
Exactly. And for a suprarenal aortic injury, you execute a left medial visceral rotation.
The text also highlights a really specific technique for repairing those major vessels once you have them isolated. The parachute technique.
Oh, this is such an elegant surgical move.
It's a brilliant spatial solution for vascular anastomosis, right? Especially when dealing with tethered vessels like the thoracic or abdominal aorta that you just cannot easily rotate to see the back wall.
Right, you can't just flip the aorta over.
So how does it work? You pass the continuous suture along the posterior wall while keeping the two vessel ends physically separated by an inch or two.
Exactly, you leave that gap. Then, once the posterior bites are placed, you gently pull the suture tails.
Okay.
And the two ends of the vessel slide down the threads, literally like a parachute descending, and approximate perfectly.
Wow.
It guarantees precision placement on that highly inaccessible posterior suture line.
That's amazing. Now, in damage control, you are opening the patient up as widely as possible to save their life. But the ultimate evolution of surgical technique is the exact opposite.
Minimally invasive surgery.
Right. Achieving the same anatomical fix with almost zero collateral damage. The manual frames MIS not just as a set of tools, but as an entire philosophy of surgery.
It really is a philosophy. To operate with minimal access, you have to artificially create a working space inside the body. For abdominal procedures, that means establishing a pneumoperitoneum by inflating the peritoneal cavity.
Now, inflating a patient's abdomen with carbon dioxide always seemed slightly counterintuitive to me.
Oh, how so?
Well, you are actively pumping CO2 into the body, which gets absorbed across the peritoneum and causes a respiratory acidosis. Why not just use room air or pure oxygen?
That's a great question. The choice of carbon dioxide is entirely driven by its solubility coefficient in blood.
Okay.
If you inadvertently inject 50 cubic centimeters of room air, which is mostly nitrogen or oxygen, into a vein, it creates an insoluble gas bubble. That bubble travels to the right heart, causing a fatal air embolism.
Oh, wow. So nitrogen just won't dissolve.
Exactly. Carbon dioxide, however, is highly soluble. It dissolves rapidly in plasma, minimizing the risk of a lethal embolus.
That makes perfect sense.
And the resulting hypercarbia and mild respiratory acidosis are easily managed by the anesthesiologist, simply increasing the patient's minute ventilation.
Got it. Now, accessing that space is where the highest risk of iatrogenic injury actually occurs.
Yes, getting the initial port in is the most dangerous part.
The direct puncture method requires using a vented stylet or a trocar with a safety shield to ensure you don't blindly drive a sharp instrument straight through the bowel or the iliac vessels.
A nightmare scenario.
Truly. But for extraperitoneal spaces, like accessing the adrenal glands or doing extraperitoneal hernia repairs, the balloon dissection technique is fascinating.
It's very clever.
You pass a specialized balloon trocar into the potential space, inflate it to shear the tissue planes apart, deflate it, and then maintain the new chamber with low-pressure insufflation.
It creates a perfect little workspace.
Right.
But because you are working through these tiny ports and looking at a monitor, you lose the ability to apply direct manual pressure to bleeding vessels.
You can't just put your finger on it.
Right. Therefore, a deep understanding of the physics of electrosurgery is non-negotiable.
We primarily use monopolar and bipolar energy. With bipolar current, the electrons flow only between the two adjacent metal tips of the instrument.
So the tissue clamped between them completes the circuit.
Exactly, providing precise small vessel coagulation with minimal thermal spread. But monopolar energy is far more dangerous.
Yes, because the current flows from the active electrode tip through the patient's entire body to a dispersive grounding pad on their thigh.
And this introduces a severe risk unique to laparoscopy called capacitive coupling. I really want to break down the physics of capacitive coupling because it is terrifying if you don't understand it.
It really is a hidden danger.
A capacitor is essentially two conductive materials separated by an insulator. In laparoscopy, your metal instrument is the first conductor. The surrounding abdominal tissue is the second conductor. And the plastic trocar sleeve acts as the insulator, or the dielectric.
So the metal instrument stores electrical charge, and because the alternating current changes direction rapidly, it induces a charge across the plastic insulator into the surrounding tissue.
So if that plastic trocar is resting against a loop of bowel,
The stray energy bleeds off straight into the intestine.
you could unknowingly cause a severe thermal burn to the bowel simply by holding an active electrode inside a plastic trocar.
Exactly. The surgeon sees absolutely nothing on the monitor.
But days later, the patient presents with peritonitis from a delayed fecal fistula due to thermal necrosis.
Which is why mastering the physics of the instruments is as important as mastering the anatomy.
Speaking of instruments, here's where it gets really interesting. I have to challenge the ongoing hype around robotic surgery.
Ah, the robots.
We see robotic platforms heavily marketed for everything from laparoscopic cholecystectomies to Nissen fund applications, but the Schwartz manual casts a remarkably critical eye on this. Does a multi-million-dollar robot actually provide a better clinical outcome for these routine procedures?
The clinical data presented in the text suggests it really does not.
Interesting.
Yeah, I mean, while robots offer three-dimensional visualization and wrist-like instrument articulation, studies show no significant difference in ultimate clinical outcomes for routine general surgery procedures compared to conventional laparoscopy.
So the technology is outpacing the clinical benefit.
For these bread and butter cases, yes. The equipment is bulky, it limits the assistant's access to the patient, it increases operative time, and the cost is just astronomical.
Right. Well, this philosophy of minimizing trauma and rigorously evaluating outcomes applies directly to those exact bread and butter cases you see every day on a general surgery rotation.
The most common surgical diseases?
Let's look at appendicitis. The history here perfectly mirrors the evolution of surgical thought.
It's a great historical arc. In 1889, Charles McBurney published a landmark paper that defined the precise point of maximal tenderness for acute appendicitis.
The famous McBurney's point.
Yes. He located it 1/2 to 2 inches inside the right anterior spinous process of the ilium, on a line drawn straight to the umbilicus.
And over a century later, identifying McBurney's point remains a foundational clinical skill for every medical student.
Absolutely.
Yet, while the diagnostic landmark remained constant, the operative approach underwent a massive paradigm shift in 1982. That's when Kurt Sem, a gynecologist actually, performed the first successful laparoscopic appendectomy.
He proved you didn't need a large muscle-splitting incision to safely remove an inflamed organ.
And we see the exact same principle applied to the gallbladder. Laparoscopic cholecystectomy is now the most common major abdominal procedure in the Western world.
And for that procedure, the critical view of safety is paramount.
Right.
The text emphasizes identifying the cystic artery lymph node as a reliable anatomical landmark. Once located, you meticulously dissect out the cystic artery and the cystic duct, clipping and dividing both.
And if the gallbladder is acutely inflamed, gangrenous, or just packed with stones, you must deploy a plastic retrieval bag inside the abdomen, place the gallbladder inside, and pull the bag through the port site.
Because you have to prevent wound infections and tumor seeding.
Makes total sense. Okay, let's tackle inguinal hernias. Repairing a hernia is fundamentally a mechanical engineering problem. The structural integrity of the abdominal wall has failed.
Yes, it's a hole in the fascia.
For over a century, surgeons utilized the Bassini method, introduced in 1881. And Bassini's approach was a massive leap forward because he actually opened the aponeurosis of the external oblique and reconstructed the inguinal floor.
He created a triple-layer repair by suturing the transversalis fascia, the transversus abdominis muscle, and the internal oblique muscle down to the inguinal ligament.
But the mechanical flaw with the Bassini repair is tension.
Right, the tissues are being forced together.
You are dragging tissues together that are not naturally opposed. It is like taking a hole in a highly stressed pair of denim jeans and forcibly sewing the edges together.
That's a great analogy.
The moment the patient coughs or lifts something heavy, intra-abdominal pressure spikes, and the sutures simply tear right through the muscle fascia, causing a recurrence.
Which is exactly why the Liechtenstein tension-free hernioplasty became the gold standard.
To mesh repair.
Right. Instead of pulling the defect closed under tension, you lay a piece of polypropylene mesh, typically 15 by 8 centimeters over the defect. You suture the mesh to the surrounding fascia.
And what about the spermatic cord?
To accommodate the cord, you make a slit at the lateral end of the mesh, wrap the two tails around the cord structures, and sew them together. This creates a shutter valve effect at the internal ring that reinforces the floor dynamically without any tissue tension.
Now, I want to challenge a specific management strategy mentioned in the text regarding asymptomatic inguinal hernias.
Okay, let's hear it.
Watchful waiting. If a hernia is a mechanical defect in the fascia, physics dictates that intra-abdominal pressure will inevitably make it larger over time.
That is true.
So why on earth would you advocate watchful waiting and risk an incarcerated strangulated bowel? Why not just fix the structural defect immediately?
It is a valid concern, and, traditional teaching did advocate for immediate repair to prevent strangulation.
Right.
However, large randomized controlled trials have shifted this paradigm completely. The data shows that the actual risk of acute incarceration in a truly asymptomatic inguinal hernia is remarkably low,
Like how low?
often less than 2% per year.
Oh, wow.
Conversely, the risk of chronic post-herniorrhaphy neuralgia, which is debilitating nerve pain from scar tissue, entrapping the ilioinguinal or genitofemoral nerves after mesh placement, is statistically significant.
Ah, I see.
So, watchful waiting avoids inflicting a chronic pain syndrome on a patient who currently has no symptoms, reserving the operation for when the hernia becomes genuinely symptomatic.
The data dictates the intervention, even when it goes against our instinct to immediately fix a mechanical defect.
Exactly.
Well, to synthesize all this clinical wisdom for your own mental review, let's do a quick exercise.
This raises an important question for you, the learner, to test your synthesis of the material. I'll give you a two-part clinical scenario review.
Perfect.
Question 1. A patient presents with acute right lower quadrant pain. You palpate the abdomen exactly 2 inches inside the right anterior spinous process of the ilium. What is this clinical landmark called, and what historical figure is it named after?
Take a second to think about it.
The answer is McBurney's point.
Okay, hit them with question 2.
Question 2. A trauma patient with massive abdominal bleeding becomes hypothermic and coagulopathic. What is the immediate surgical strategy, and what core temperature must be reached before definitive repair?
Think back to the flooded house analogy.
The answer is damage control surgery, and the core temperature must reach 36 degrees Celsius.
Awesome.
Perfect.
Whether you are identifying McBurney's point or holding off on a vascular anastomosis until the patient hits 36 degrees, the overarching theme is undeniable.
The physical act of cutting and sewing is secondary. True surgical mastery is the deep, systemic understanding of the patient's physiology. You are managing the entire biological environment.
And that leads to a profound final thought regarding the future of this field. Throughout this deep dive, we have discussed surgery as a mechanical intervention, tying knots, clipping arteries, placing synthetic mesh.
The mechanical arts.
Right. But the Schwartz manual points toward the horizon of genomics and molecular surgery.
Yes. The research is aggressively advancing in molecular biology, targeted gene therapy, and stem cell tissue engineering.
So if we reach a point where we can reverse cellular hypoperfusion at the mitochondrial level or manipulate tumor genomes to self-destruct without ever making a physical incision,
It's a wild thought.
will the mechanical act of surgery eventually become an obsolete artifact of medical history? Will the surgeon of the future wield a scalpel or a customized genetic sequence?
It completely reframes what it means to heal.
It really does. Thank you for joining us on this deep dive into surgical mastery. Keep studying the underlying mechanisms, keep pushing back on dogma, and we will see you next time.